Good evening and a very warm welcome to all the doctors who have joined today's webinar. I am Neetu Abraham, Community Manager at MediSage eLearning. At MediSage, we empower doctors with the right blend of knowledge and technology to enhance clinical practice and patient outcomes. With AI transforming healthcare, we are excited to introduce Sage AI, a medical grade AI built exclusively for doctors. The entire webinar is co-powered by Sage AI, reflecting our commitment to bringing cutting edge intelligence directly into everyday clinical decision making. Sage AI is now freely available on MediSage app. On behalf of MediSage, I am now delighted to welcome you all to Sexual Health Ki Pathshala, episode 7, where today we will be discussing on the topic genito-pelvic pain or penetration disorder. With this, now I would like to hand over the session to Dr. Shama Sultana ma'am for further proceedings. Over to you, ma'am.
Thank you, Neetu. Good evening, everyone. A warm welcome to all the respected faculty and distinguished guest healthcare professionals and participants joining us today for Sexual Health Ki Pathshala episode 7, presented by SexMed Connect in association with MediSage and Sage AI. I request Neetu to share video on Sage AI.
Uh, sure. Can you see my screen?
No, still
Yes.
not. Yeah,
Yes.
now so.
So this is an AI tool exclusively for doctors, wherein doctors can get help with diagnostic support, creating presentation, checking drug-to-drug interaction, and also deep research about any topic. So this is just a gist of how the AI tool works. If you want to explore more, you have to download MediSage app and then register yourself as a doctor, and then you can start using Sage AI. You can also create your presentation now using Sage AI, wherein after entering the topic and number of slides, even the slides can be created in Hindi and Marathi. Slides will be created for you. I mean, the content will be created for you. This is patient treatment plan, wherein you can create entire treatment plan for your patient using Sage AI. That's it. Thank you for giving me this opportunity.
Thank you, Neetu. And now here we are introducing SexMed Connect, a dedicated academic forum created for obstetricians and gynecologists to learn, discuss, and share knowledge on various aspects of sexual health and wellness. SexMed Connect is a platform aimed at bridging knowledge gaps, promoting evidence-based practice, and encouraging open academic discussions on sensitive and essential sexual health topics. Through webinars, discussions, educational videos, and interactive sessions, this forum strives to empower healthcare professionals with updated information and practical insights. Our mission is to enhance patient care by helping clinicians stay informed about the latest research, treatment approaches, and best clinical practices in sexual medicine. At the same time, it provides an opportunity for networking, collaboration, and exchange of experiences among peers across the country. So, SexMed Connect actively engages its members through multiple digital platforms, including the WhatsApp academic discussion group, Instagram updates, YouTube educational content, and Facebook academic posts, and thereby creating a vibrant and continuously evolving learning community. So, together, let us continue to break barriers, encourage healthy conversations, and improve awareness and care in the field of sexual health. So, without any delay, I would be honored to introduce our office bearers, Dr. Neeraj Jadhav sir, Dr. Apurva Datta sir, and Dr. Naisargi, our joint secretary. Dr. Neeraj Jadhav sir, President, you have any points to introduce, sir?
No, it's okay. You can go ahead.
So I request Dr. Apurva Datta sir, anything you want to talk about?
Yeah. Thank you so much. And thank you so much, Dr. Tania, to join and give. We are really waiting to know this very untouched topic about the pain penetration disorder. And thank you so much for accepting our invitation. And we are eagerly waiting. All the delegates are eagerly waiting to listen and learn from you. So thank you so much for joining. And thank you, Sama, for conducting.
Thank you, sir. Dr. Rinku Lodha-Negi ma'am, my co-moderator, I would like you to introduce our speaker today.
Thank you, Dr. Sharma. It is my privilege to introduce our very distinguished speaker, Dr. Tanaya Narendra. Dr. Tanaya is an award-winning Oxford-trained doctor with expertise in reproductive medicine, clinical embryology, and public health communication. She completed her MSc in clinical embryology from University of Oxford and is currently associated as a clinician in reproductive health and fertility with Abhilasha Hospital and Fertility. She is also a pioneering medical educator, best-selling author, and public health advocate, and has redefined public health education in India. As the force behind Dr. Cuterus, she has made conversations around reproductive health, sex education, and body literacy more accessible, evidence-based, and inclusive. And she has a very huge social media following, over 1.8 million followers on Instagram and over 60,000 subscribers on YouTube. So that's quite phenomenal. And she's also the author of India's first national best-selling book on sex education. And her contributions to public health have been recognized globally, including those by WHO and Bill and Melinda Gates Foundations. So I warmly welcome you, Dr. Tanaya, and I invite you to deliver your talk on genito-pelvic pain penetration disorder. I'm sure we'll have many, many insights and a lot of things to take back.
Thank you so much for such a warm welcome. This is an absolute delight to be here, and I'm really, really happy to be talking about, such an issue that is so close to my heart, because we see this very often and it's so quickly misdiagnosed, underdiagnosed. We have a very big global burden for it. So today we'll talk a little bit about the diagnosis. We'll talk a little bit about the differentials. How do we assess it and how do we manage it? Ma'am, can we do the next slide, please? So if you're seeing about 10 patients in a day, 1 on 10 of those will have significant pain, fear, or inability associated with penetration or pelvic contact. Now, global prevalence can range anywhere between 7% to 45%, depending on what age group we're talking about. So it is a very, very massive subgroup that is struggling with these issues. But the problem is that the Indian data is severely underreported. And can we do the next slide, please? Now, global data, premenopausal issues are anywhere between 14% to 34%. The incidence and prevalence is a little bit underreported, and a lot of the data is extrapolated from very limited conversations and very limited studies we have on this. Postmenopausal, we are seeing that there's a very significant number that is presenting with it. Again, underdiagnosed, under-researched. And what we're seeing is that there's a very significant presence of comorbidity there. Almost 50% of women with GPPPD also have another pain disorder, say fibromyalgia, interstitial cystitis, or IBS. And they also see an association with other sexual dysfunction, such as female sexual interest or arousal disorder, and they also see a low satisfaction in their sex life. So this is extremely common. We are seeing it very, very frequently. And a big shift that has happened in the past few years is that earlier we had two umbrellas. Ma'am, we can go to the next slide. We had two umbrellas. So patients would who had penetration issues would either be classified either as vaginismus, so more of a psychosexual issue where there would be an involuntary vaginal spasm preventing penetration, or they would be classified as dyspareunia, where there would be recurrent genital pain which would be associated with sexual intercourse. And what we saw with a lot of research and a lot of data, particularly this Rising et al. Paper from 2004, it made it very clear that there's a significant overlap. These are not two separate entities. These are not two distinct entities. And a unified diagnosis was made where we reclassified this as genito-pelvic pain or penetration disorder, because to address the overlap. So since DSM-5, which is in 2013, since then we have reclassified this into GPPD, which is a new diagnosis, and it's super important that we address it. Ma'am, can we do the next slide? So what are the diagnostic criteria? We are looking for one or more of the features. 4 features. There has to be significant distress. It has to be over 6 months duration. So I'm not going to be including infective pathologies here. I'm not going to be including things that are transient in nature. And they have to be things that are not explained by another condition. So it has to be specific to this. Now we're looking for genital or pelvic pain that is marked vulvovaginal or pelvic pain during vaginal intercourse or during penetration attempts. There has to be some fear or anxiety around it. So there has to be a marked fear or anxiety about this penetration. So either in anticipation of this penetration, during this penetration, or as a result of this penetration, before, during, and after. All 3 of these times are involved. There has to be a pelvic floor tension. So we can see the pelvic floor muscles contracting. Visually, we can see changes in anticipation or in fear, or just the cycle that gets set up around anxiety around penetration. And we can also see avoidance of any penetration, and this could be sexual or non-sexual. It doesn't necessarily have to be sexual penetration. Now there can be subtypes here which we need to mention specifically when we are taking this history. Document the subtype, because that really impacts what sort of clinical care you're going to be giving there. What is the treatment pathway that we will follow? So for somebody who comes from, say, a very negative environment around sex, or a very significant fear around the idea of sex, and from the very first penetration, there has been a generalized anxiety or pain. So this would be a lifelong case, present from the first attempted penetration, and it is often associated with a stronger fear avoidance pattern. Obviously, this takes a longer treatment trajectory. For somebody else, this could be acquired, say, after trauma. This could be sexual trauma or physical trauma. There could be birth, there could be surgery, there could be hormonal shifts. For example, in genitourinary syndrome of menopause, we see this. So there is a period of normal sexual function, and after that, they develop GPPPD. Now, this could be of 2 types. Like I mentioned, sexual and non-sexual. So if it is generalized, it is appearing in every single context. Doesn't matter who the partner is. Doesn't matter if the penetration is sexual, or it is a gynecological examination, or it is even it's even a tampon insertion. These people are not able to completely relax. And I don't want to, I want to be very cognizant of the word I'm using here, relaxing, because we say this very often in our OPDs. We tell them just relax, but this is not just a relaxation issue. This is not a willful issue. It could also be, aside from being generalized, it could also be situational. For example, it's only happening around penetration time. So this could be associated with a very significant fear of sex or negative attitudes around sex. Some of my patients who have situational GPPPD, they are able to enjoy oral sex, but they will not be able to have penetrative sex. So it's not that sex is completely ruled out. Another important qualifier here is that incomplete penetration, attempted penetration, all of these also come under GPPD. So it's not that if penetration is happening, this can't be GPPD. We have to include that. So as we can see, there's a very significant overlap. The Venn diagram intersects here because we saw that with the older classification, it was very rigid. We had either vaginismus or dyspareunia, which was, indicating that there is either a psychological component or there's a physical barrier there, or a physical component there. Sorry, ma'am, can we go to the previous one, please? So pelvic floor spasm and the pain, they frequently coexist. And when we are only treating one of the other, we are failing the patient. And here is the one single keyword I want to focus on, that we focus on in sexual medicine now, which is the biopsychosocial approach. We cannot see this in one single way. We have to address the biology, we have to address the psychology, and we have to address the sociology, especially in a country like India. Can we go to the next one, please? So there is a fear of pain. Now, this pain could be real because of actual physical issues, or this could be an anticipatory pain, which will create a fear and hypervigilance. Because of that fear, there is a muscle guarding that is happening, and there's avoidance that is happening, which leads to an increased sensitivity. And there's actually nociceptive pain that is happening here. This is not just psychological. All of this leads to more anxiety, which leads to more pain. This is a neuroplastic pain reinforcement, and these are the same mechanisms we see in chronic low back pain and fibromyalgia. I really want to emphasize this because for a lot of young women who I have spoken to, actually not just young women, a lot of women that I have spoken to in learning about how sex ed is treated in India, I have learned over and over again that repeatedly they are told, not just by medical professionals, but by non-medical people as well, that just relax, this is in your head, this is in your head, but there's an actual pain mechanism here. We understand the nociception here. Can we go to the next one? And why I want to emphasize the psychosocial layer, especially in India, is because there's so much shame and silence and guilt around sexuality. A lot of young women are taught that there will be pain when you have sex. There's normalization of pain. There's no sex education. There's a lot of negative connotations regarding sex, like fear of injury. There's virginity myths. All of these things respond very well to CBT. We have great data to show that. Anxiety and depression are comorbid issues. They are consequences as well as predisposing factors. So we have to address those as well. Obviously, we all know the stats. We all are very well aware that there's a very high burden of sexual trauma in India, and that really elevates the risk. We have to be cognizant of never assuming. So this is a gentle question you can ask. Have you ever had any difficulties around sex, or have you ever had any difficult experiences around sex or with your body? This is a gentle question, and more often than not, your patients will open up and say yes, which can form a very strong foundation of future somatic issues there. And of course, relationship dynamics, which are super important in India. There's so much pressure around consummation, around fertility. It leads to marital problems. So psychological factors will amplify as well as maintain the GPPD. They are not causative factors, but it's important to address these and speak about them with the patient for their own acceptance of the treatment. Can we do the next slide, please? So I'm not going to explain the anatomy in detail. I think we're all dealing with sex med, so I will not bore you with the boring bits, but there is a lot of hypertonicity we can see. And how we see that is because there's biofeedback evidence. So if there's surface EMG studies, when the tone of the muscle has been measured, it is objectively and measurably increased in patients with GPPD. This is not just a voluntary thing. There's a muscle spasm that is happening, and for any muscle spasm we don't tell them that is voluntary except for this one. So there's a conditioned protective response and there's no willful resistance that's happening. So these examinations have to be very, very gentle. And if a speculum examination or even a generalized local examination is triggering this reflex, please document this, but do not repeat those examinations over and over again unnecessarily, because the more and more we do that, the more and more those pain pathways get reinforced, and we want to break that pain cycle. Can we do the next one, please? So I want to keep driving home this point. This is a pain disorder. This is not just psychological. There is a central sensitization because the neural signaling changes. Allodynia is pain that is occurring to a non-painful stimuli. So even touch can precipitate pain in patients like this. So tampon use or gynecological exams can create distress here. We can actually see histological changes here. There's a mast cell infiltration that is happening. There's increase in pain generation. There is a we can see long-term neurological effects in the CNS with response to chronic pain, and we see it in other conditions as well. We see it here as well. There's more the C fiber stimulation. It leads to an amplification, and the pain that is happening over and over again, the system repeatedly gets resensitized. So there's a very, very significant build-up of pain, and these are patients who have a pain hypersensitivity. Can you do the next one? Now, a lot of times when you're speaking to these patients, they will say that I don't think I'm anxious, I'm just scared, but I don't think I'm actually anxious. But when you clinically examine them, you'll see there's tachycardia, there'll be an adductor contraction, there'll be gluteal tightening, they'll hold their breath, they'll withdraw. A lot of times patients physically shove you away. So they may not be able to consciously articulate it, but we do know that there's a very significant pain cycle that gets established. Can we do the next one? There are other factors as well. There's hormonal contributions. So it's not just again, not just psychosomatic. I feel like I keep saying that over and over again, but I think that's really important to emphasize. One of the most common things we see is postpartum. So there's a drop in estrogen levels, which can lead to dryness, thinning, and dyspareunia in the vagina because of this loss of estrogen. This also continues in the breastfeeding period when patients are reattempting sex after their deliveries, which is already such a, emotionally testing time. Then there is also physical anxiety around how penetration will happen, given the changes that happen in the body post-birth, given that the vagina is still sensitive and recovering. On top of that, there's a lack of estrogen. So there's that very important thing. One of the new areas that is really coming up these days with more and more research is the COCP-induced vestibulodynia, because COCPs over a long period can suppress ovarian androgens, and at the vestibule, there can be an alteration in the receptor expression. So with these patients, once you stop the pill, and as a very, very big fan of the COCP, I personally feel very bad advocating for, COCP-induced vestibulodynia, but it is a real thing that we are seeing right now. More and more research is coming out about it. So this provoked vestibulodynia does resolve after stopping the pill. We'll discuss provoked vestibulodynia in more detail in the DD. But ma'am, can we go back to the last one? There's one thing that is coming out new in only, I think, 2024 or 2025, we got the official term genitourinary syndrome of menopause, and same issues as hypoestrogenism. Because there's long-standing estrogen withdrawal, there's vulvovaginal atrophy, which leads to dyspareunia and recurrent infections. Very, very common, massively undertreated, very easy to treat, local estrogen. And in 2026, the black box warning on this local estrogen has been lifted. So we are very much at the, at the turning point and at the absolute revolutionizing time in this. And there's also a lot of talk of using testosterone for GSM as well right now, topically. But no international guidelines have been really formulated here. Similar conditions with a reduced androgen insufficiency because of reduced testosterone. Obviously, tissue health is affected. And here we are having some good evidence in using DHEA vaginally and locally, but only for postmenopausal women. Can we go to the next one, please? So let's discuss the DDs. What are the things we are wanting to rule out for sure? Now, the Q-tip test, the, what is it called, earbud. My model is broken, so this might fall apart at any moment, but I'm just going to try to demonstrate. So we want to use a Q-tip. It's very important to use a Q-tip, an earbud, or a cotton swab, because we don't want to elicit pain right away from pressure. If something as gentle as this is eliciting pain, that is telling you that there's an underlying pain receptivity issue. So on the vestibule, my laptop's about to die, sorry. Okay. On the vestibule, if a patient is constantly reporting in the vestibular area or in the vulval area, if there's a constant burning or pain, whether or not you're touching them, even on wearing their underwear, there's constantly a raw, burning, irritated feeling, then there's a neuropathic component. This we will not try to address here. I personally, if I get somebody like that, I just send them to a neurologist for amitriptyline or gabapentin. Pelvic floor physiotherapy can help here, because again, there's the pain fear avoidance cycle that has been established along with CBT or psychological support. But the main treatment definitely has to be neuropathic agents. Without this, we are not able to address the nerve pain component here. Provoked vestibulodynia is when you take a Q-tip, and particularly around the posterior area. So 4 position, 6 position, and 8 position around the vestibule. If we even touch or even put slight pressure with a Q-tip, patient will experience pain. This is very commonly seen, as we just addressed in the last slide. There is a very strong association right now we are seeing with COCPUs, and also with people who have a hypertonic pelvic floor. So patients who tend to be generally anxious as well. I have seen this quite often with young women who are very high performing individuals and are very anxious and very, control oriented. Here, pelvic floor physiotherapy, topical therapy, CBT, and limited evidence of vestibulectomy can be used over here. Can we do the next one? Okay. This is a very, very important condition that gets missed super, super often, lichen sclerosis. I should have attached a picture here, I'm sorry. But over here, what you will see is there'll be a white or crinkled atrophic kind of appearance. A lot of times for young patients, it's dismissed as smegma, but actually it is atrophic vulval tissue. And there'll be ecchymosis, there'll be labial fusion. If it's very, very advanced, the clitoral phimosis can happen. It can also happen in GSM. So this is something to watch out for. But sometimes you can even see this in pediatric patients. So in premenopausal as well as pediatric patients, this is something that gets missed very quickly. There's a loss of labial architecture, which obviously leads to an introaortal narrowing and fissuring. This will obviously lead to pain, which gets misattributed to vaginismus. The thing is that the diagnosis is mostly clinical. Sometimes we can take it to a biopsy if there's a confusion around this, if the clinical picture is not entirely clear. Very often for younger patients, we do assume that there is an unclear diagnosis here. So we can go for a biopsy, but what is super important in this case is that we need to do long-term follow-up these patients, because there's a risk of malignant transformation. And if that is not the case, while we are still following them up, treatment is simple. Topical steroids, ultra potent, but topical steroids. We can involve a colposcopist here if needed, but this is a diagnosis I hope we all keep in mind with young patients. This is something that gets missed very, very often, and it's a purely biological thing here. Can we do the next slide? A very, very common query that I get from all the other doctors I've spoken to is, how do we differentiate between endometriosis associated dyspareunia versus actual GPPPD? So with endometriosis, we'll have classical deep dyspareunia that will happen with deep penetration or thrusting, often worsens premenstrually because of the proliferative phase. There might be a Poucher-Douglas involvement, there might be uterosacral ligament disease, there might be rectovaginal nodules. This will require a multidisciplinary treatment. This will require a endometriosis specialist, at least a gynecologist, if nothing else. And of course, we have imaging studies here. Treatment will involve the hormonal suppression, excision surgery, or pelvic floor therapy as well. It has been really helpful in some of the data that I have seen. When we are experiencing superficial dyspareunia, for example, there's pain at entry or immediately on insertion. These are not areas where you see endometriosis lesions usually. So if you're seeing them on the vestibule area in the pelvic floor, think of vestibulodynia, think of pelvic floor hypertonicity, think of GSM, think of lichen sclerosis. And this is a very important feature, that a negative laparoscopy does not mean there's no diagnosis. There was just a recent paper that came out redefining how endometriosis diagnosis is happening. I actually haven't read it, so I will not speak on that. But it came out last month, if I'm not wrong. But here is where you can involve a SexMed team. You can involve pelvic floor physiotherapy before we go through invasive things like laparoscopy. Very, very, very important one. This is what I see most of my bulk patients come from this. Recurrent candidiasis is their diagnosis, or they have self-diagnosed and they have repeatedly treated themselves with antifungals. Now, the relief that comes from the antifungals could be placebo, could be coincidental, could just be local emollient therapy. But there will be recurrent burning, itching, and painful sex. As soon as they use this, symptoms resolve, symptoms come again, they use another antifungal, and then the cycle keeps repeating for years and years and years. I've had a patient who has been put on year-long vulval candidiasis therapy, and she actually just had vaginismus straight up. So we want to make sure we are differentiating. Another important thing here is that with GPPD, we see more burning compared to itching. That is a very, very good clinical diagnostic factor. You will not see nighttime itching, the classical thing that we are looking for. You will not see that. You will see normal pH. You will see no hyphae in the microscopy. And these are things to look out for that can really help with figuring out what we are actually seeing. And we'll also see that the pain is only coming with penetration. It's not constant, or there's no constant burning sensation that's happening. So this is where our real clincher lies, the history taking. This is where most of the time we can really make simply a diagnosis. There is not extensive examination involved. One very important question that I feel that I have personally missed out on several times when speaking about this pain is, I always ask, when did the pain start? But what was the concurrent life issue happening at that time? One of my patients that I found is just an extremely incredible example. Is she had a partner, she had a boyfriend, they were together for 10 years, they were sexually active together, they got married, and immediately after marriage, she could not have sex again. Because this is a very interesting story. Concurrent issues are super important here. When they were going for their first night, she saw that her father-in-law was peeping from the outside to make sure that the marriage is getting consummated. And since then, she got these very bad self-image ideas, and also her husband did not take a stand for her. So relationship breakdown happened, which is another very important thing that happens in these issues. And she really, really struggled with somebody who was a very sexually explorative person, really struggled with their own sexuality after that. So concurrent issues are super important. Where is that pain happening? This is very important in ruling out endometriosis or ruling out a differentials, essentially. And does the pain always happen, or the pain is only happening with penetration? So this is again great for spontaneous versus provoked. Understand the relationship history. That simple question, are you having any trouble with sex? That's a great opener for these kind of conversations. We can assess fear and avoidance, but I think this is a more extensive conversation. I know that a lot of times we don't have the time to get into this, so that's okay. But how many antifungal courses is a great question to ask, because a lot of times patients self-medicate and don't get a resolution. Okay, can we do the next slide, please? Simple assessment tools. These are great to see if the treatment is going well, to understand the pathway, and to also for initial screening. So we can use the female sexual function index. There's 2 questions here that are quick to ask. How often do you experience discomfort or pain during vaginal penetration? Question 1. And do you experience these following penetration? Now, patient can rank them on a scale of 5. I've linked the questionnaire in the end of the slide, but you can just ask this question outright. It's a simple question. Then we use the numerical rating scale. How bad is the pain between 0 to 10 right now, on average, and after treatment? So with my patients, I just ask them to make a chart when they're doing their own dilator therapy, and I ask them to rate it every single day. How was the pain today? I also ask them to add an orgasm before that dilator therapy, because that really helps relax them and put them in a positive state of mind before they are attempting any dilator therapy, but this is, not super evidence based really. I mean, I don't think anybody's conducted a study here. Cotton swab test, this, like I mentioned earlier, 4, 6, and 8 are the main areas we're looking at, but if we can do a full mapping of the vestibule, 2, 4, 6, 8, 10, 12, and the patient will give a pain scale. How much pain are they feeling between 0 to 10? And you can have your nurse do this, you can have your paramedical do this. This is not something that really will take up a lot of your time. Then another scale that is useful, I personally haven't used it, but it's in the data, so I thought it's worth mentioning, is the PGIC scale, which is where we understand how does the patient feel that their pain is changing. This can be really helpful to reestablish in their head that this treatment is working. This is the gold standard treatment outcome in pain trials, and this is more than for us. For them, it is very good in rewiring their brain. And then pelvic tone assessment. This is something I struggle with in India so far. I have not found a good enough physiotherapist who is able to assess levator ani resting tone and tenderness and voluntary control, or can do a manual release. I have not found one. If anybody knows, please share their contact. I'd be really happy to get in touch. Now let's talk about treatment, and we'll go from first line to third line based on the hierarchy of evidence. Number one thing, pelvic floor physiotherapy. This is the game-changing thing that comes for any patient with any GPPD. A lot of us come from smaller towns where we don't have access to pelvic floor physiotherapists. I am personally from Allahabad, and I don't have a pelvic floor physiotherapist in Allahabad. So here what we do is, you will not be able to do biofeedback training or manual therapy. Manual therapy to India mein only, I've never found anybody. But biofeedback training you can't do here. So here what you can do is you can focus on progressive dilatation for your patients. One thing that I have found very useful that my patients have always come back with is that when they do their progressive dilatation, number one, I encourage them to have an orgasm before that. Masturbation or with their partner, however it works for them, it helps take away some of the negative connotations around sex, relaxes the body. And most importantly, we also involve the partner in the treatment. This is not an individual treatment. This is ideally with the couple. And when we're doing the dilatation, so we do 3 things. Number one, try to keep it at the tip, hold it long, then try to insert it. And lastly, hold it inside for up to 2 minutes. What we also do is we make the partner also insert it, because that can then recreate the experience of what sexual intercourse, penis and vagina sexual intercourse is going to be like for them. And that can also be a really good bonding exercise between the partners. So it also works as sex therapy or couples therapy in that way. Breathing techniques are absolutely game-changing for these patients. It sounds like such a simple thing, but just 4-7-8 breathing or box breathing before they attempt any of these exercises, incredible results. Self-massage, sensate therapy with their partner, all of these things, we want to take away the fear. If somebody has access to a good pelvic floor physiotherapist, you can also include biofeedback training. This is the gold standard in retraining the pelvic floor. There's surface level EMGs and down training, so the patient can actually physically see that this is also not in their head, and there's a real physiological change that is happening, and that really helps. Let me do the next one. Topical and hormonal therapies, again, greatly underutilized and greatly overutilized. A lot of patients are immediately given topical lidocaine. There's much better methods there, but also for some patients it helps. Data shows us that there's significant pain reduction, but I feel like as long as the biopsychosocial model is not being worked on, if we're only working on the bio model, it's not going to be a complete treatment. So I'm not a very big fan of this, but data shows us that it can be used nightly for desensitization, apply 15 to 20 minutes before penetration, and there's decent results. I'm a very big fan of topical estrogen, especially for GSM or vulvodynia when it's COCP induced. So first line treatment for COCP or postpartum or COCP induced, GSM, COCP induced and postpartum cases, the black box warning was recently removed. So this is safe for breast cancer patients as well, as long as it's only being used locally. Ospemifene is not available in India right now, but it is being used. It's a SERM, so it's a great option for postmenopausal women who are not able to use estrogen locally. But not available in India, so I will not harp on about this. This is a great thing that is being investigated right now. We're seeing very good data for vestibulodynia, and of course for GSM is topical DHEA. This is also used a lot in fertility. So great product. And it works by converting locally to estrogen and testosterone. So we get local hormone therapy. There's no systemic side effects, and patients are really enjoying it. All of the hormone withdrawal that happens in GSM, very helpful there. Can we do the next one? Psychological interventions, again, gold standards, but we might struggle with finding the right people in this. If you find a great therapist, psychotherapist, pelvic floor therapist, stick with them. They are one of the greatest relationships you will build in your sexual medicine clinic. CBT, we have excellent data. 70% of women achieved successful intercourse at follow-up in this landmark paper from 2009. Couples therapy is great. Sensate focus is very simple for people who don't know what sensate focus is, where we're just encouraging touch. It doesn't have to be sexual touch. You want to take away the fear around touch and intimacy, and that can be very helpful. Masters and Johnson's, obviously. Mindfulness based therapy here, breath work is very impactful. Again, it sounds like something so simple, but it's super impactful. In fact, if my patients are in a bigger city, I also encourage them to go for yin yoga, which is a very restorative kind of yoga where there's a lot of focus on breath work and relaxing the body, and that seems to be really helpful for them. Procedural interventions, the data is there for some of these things. For some of them, I'm not a very big fan of these because again, biopsychosocial, but Botox, we can use 20 to 100 units into the bulbospongiosis, so right around the introitus and or under puborectalis. Under LA or GA, there is very good data actually. This works very well, but I don't think this should be first-line therapy, and I think unfortunately, most gynecologists use this as first-line therapy. So this is something we need to ensure that this is not the first step we take. It works for people who have failed PT alone, or they have such severe muscle spasm that PT is not even going to happen for them. Vestibulectomy used a lot earlier, not so much anymore, but there's decent data. The important thing about this data is that the long-term equivalence between CBT and pelvic floor therapy and vestibulectomy is at par after 2.5 years. So why go for surgical intervention? I am a very big fan of taking the longer route, and we can try CBT and we can try PT first. But it's a valid option. Very interesting data is coming out, experimental data is coming out about ketamine infusions right now. They're using it for other pain modulation as well. Transcranial magnetic stimulation. This is all very experimental. The shockwave therapy is something that is promising, but it's not included in standard of care right now. Controversial, very common in India, but controversial data around the fractional lasers for vaginal rejuvenation. AOCG recommends against it. Evidence is mixed. Your choice. I know it's very popular in India, so I will not comment on this. Let's do the next one. What is super important in managing this is that we must have a multidisciplinary team. The patient is at the center, and all of these, the sun is the patient, and we are all planets around it. We have to have a gynecologist, we have to have a sex med physician, we have to have a therapist, and we have to have a pelvic floor physiotherapist. All of these together work on the patient. It is not something that will be fixed with one thing alone or one specialist alone. I'm a big fan of referring to people, and I'm a big fan of getting referrals as well. So if somebody has had no penetration for more than 6 months, or they're having refractory recurrent candidiasis, or there's a pelvic pain, you're not able to see any physical structural issues, there's a significant fear or avoidance of penetration or of examination, which is very common actually. I know that in one hospital, they write on the patient's prescription, they write TMN, touch me not, if a patient is just very quick to respond. So for a lot of patients, they are very anxious around any gynecological examination. So obviously, if there's an anxiety superficially, that's okay. But if there's a significant avoidance of medical care, then it is a good time to refer to people. Post-op dyspareunia after gynecological surgery, post-op dyspareunia after obstetric procedures, relationship distress, of course, And when you are referring, please mention all of the details. If you have any swabs, any biopsies, any obstetric or relationship history, any known trauma, this is a very important clincher over here. And whatever treatments that have been tried, and if they've responded and how much they've responded. So let's do a case vignette very quickly. This was the one case that really changed my opinion, because I'm a very big fan of OCPs, but 28-year-old woman, married for 3 years, referred from the third gynecologist for vaginismus. She's unable to have penetrative sex and consummation was never achieved. There have been recurrent antifungal courses, 7 in 2 years, but most recently was told we found nothing, but it may be psychological. Now on history, she's been on the COCP for 5 years. Dyspareunia started within 6 months of starting the pill. So we have a clincher right here already. History is very important here. When we did the Q-tip test at 4, 6 and 8 o'clock, patient rated pain 9 on 10. Now, pelvic floor was very hypertonic, levator ani bilaterally was very tight. The patient did not tolerate a digital exam, but when we did the cotton swab exam alone, there was no spasm. So this is a very important part of the history here. The female sexual function scale, 1.216. Now, our diagnosis here, because we're seeing that there's no spasm on cotton swab alone, we are seeing that there's a COCP-induced provoked vestibulodynia. It's not all the time, so which means it's provoked. And it happened within a few months of starting the pill. So we know that there's a COCP or hormonal indication here. Plus, there's a very hypertonic secondary pelvic floor. And there's a fear avoidance cycle that is lifelong and generalized. So this is not vaginismus alone. This is not psychological alone. This is a hormonal issue here, along with a baseline of psychosexual issue here. So what do we do for treatment here? We stop the COCP. So hormonal issues get resolved. Localized estrogen to the vestibule. Now, if I presented the same case in the US, they would have also used localized testosterone, but we don't do that in India right now. No international guidelines. They're using it very enthusiastically, experimentally. So localized estrogen to the vestibule, pelvic floor physiotherapy, 12 sessions, CBT 8 sessions with a dedicated sex therapist. And after 6 months, Q-tip sensitivity, which was 9 on 10, reduced to 3 on 10. Patient had successful penetration and the pelvic floor tone was normal on assessment. And the best part, she had no more arbitrary antifungals after this. So very good responses we see. Now, after this chat, think about this all over the weekend. But from Monday, 5 things here, actionable tips you can do. Stop the antifungal loop. We really overprescribe antifungals in our country. If the patient has had more than 2 antifungal courses with no confirmed culture results, then stop. Do a vestibular mapping with the Q-tip. Rule out any vestibulodynia, rule out lichen sclerosis and contact dermatitis, extremely underdiagnosed, especially in this weather when patients, a lot of young patients at least, are wearing these lacy panties and getting contact dermatitis right away. Ask about penetration pain at every visit. The patients coming for obstetric concerns, gynecological concerns, always ask, is sex comfortable? These patients have been wanting to be asked this by a professional, and they will come spilling out with everything. Very good relationship, very important relationship to build in your practice is to know a pelvic floor physiotherapist. It's very, very important, and it's game-changing in SexMed. Never say just relax. This is the one thing that by far every single patient has always said to me. That I've been told, oh, have a drink. Oh, get drunk. Oh, just relax. It'll be fine. Have an anti-anxiety pill. It's not something that is voluntary. There's no willful resistance that's happening here. And when we keep reinforcing this, it makes the patient feel like a failure. We have to be trauma-informed here. It damages the trust. There's a delay in diagnosis. And clinically, it's completely inaccurate. So we want to be cognizant of not saying this to our patients. And then, of course, whatever you're not able to do, document it. If they're not able to do a speculum examination, write it down. For these patients, if they're coming with, I don't know, vaginitis, then we will just do a underwear examination, show what the discharge looks like. A lot of times, getting the patient to initiate the examination or insert the speculum themselves can also be very, very helpful. But whatever you're seeing, write it down. This is data, and this can really help in getting us to a nicer diagnosis and a better treatment protocol. Thank you. That was all from me.
Thank you, Dr. Tanaya. It was a very crisp and very in-depth deliberation about the pain and penetration disorder. So thank you very much. Question, Rinku Sama, is there a question?
Diksha?
Diksha?
Yes, ma'am, sharing.
Okay.
Yes, okay.
So let me ask one question. Is topical DHA is available in India? How do you get it?
So
Topical.
they're using it in fertility. So a lot of times what they take is they take DHA pills, they mix it with saline, make a paste, and also use it locally. But it is definitely showing good results in the other doctors I've spoken to. I went to I want to say the UAE ESSM, and they were having very, very good results. The thing is, a lot of the patients that are coming with SexMed queries often have access to decent money, and they can often get it from outside countries as well. So if they're able to get it, that is great. But otherwise, they can just take supplements, make a paste, use it. I have not used it on my patients yet.
Okay. So do you prefer oral DHA or is not worth?
The data is there. I don't
Yeah.
use DHA as much because again, there's so much fertility overlap there that I don't use it as much. Most of my patients are young people who don't want any kind of, who actually are seeking non-contraceptive, are seeking contraceptive options. So I don't use it personally in my patients, but the data is very much there.
Yes, Rinku.
I have a few questions.
Yeah.
So in patients with coexisting vaginismus and vulvodynia, how do you individualize the treatment approach?
So firstly, we want to address the vulvodynia. We want to first understand, is it vestibulodynia? Is it vulvodynia? Is it provoked? It's unprovoked. It has to be first, it has to start with CBT. Once you can start there, once you can build a baseline of removing that fear anxiety cycle, which is super strong in a patient who has both these issues, we can set the stage for a little bit more receptivity. And then depending on how this vulvodynia is happening, what is the underlying pathophysiology there, we can approach treating the vulvodynia with a major chunk of your vaginismus therapy being already solved with CBT, and then including pelvic floor therapy.
So, are there any recent...
Sorry, one second.
Okay, it's okay. With the my is also there.
Sitting quiet.
And they are always attention seeking.
I haven't paid him any attention in more than an hour, so he's very angry about it.
Okay. So, are there any recent advances or validated tools for screening genito-pelvic pain in routine gynecology practice?
In routine gynecology practice, the validated tools I've already mentioned. We can use the FSFI scale. We can use the pain scale. If there's anything other than this that I don't know of, please do share it, because this will be a learning experience for me as well. But more often than not, in routine gynecological practice, patients will tell you themselves. So you don't have to go for actually, these assessment tools. History taking is the key clincher here.
All right. And what strategies have shown the best success in improving treatment adherence and couple satisfaction in these patients in management of GPPD?
I think a very, very important thing that we are really not taught in medical school at all is being trauma informed. So this is some homework we have to do on our own, is understanding how to speak empathetically and patiently. And given the patient loads we deal with, it is very difficult to do that. But that trauma informed care is really game changing when it comes to speaking with patients who have historically and repeatedly been delegitimized and invalidated, and they are coming from a very long history. They're not coming, usually you are not the first doctor these people are seeing. So building that patient's trust has to be the foundation of what we are doing. Once we can establish that, there's not a lot of work you have to do really for compliance. Then they will keep coming because they'll see results themselves. And these are women usually who come from so much anxiety and so much shame, and also repeatedly feeling like a failure in their own relationship because they're not able to, quote unquote, provide sex to their partner, that that compliance issue kind of sorts itself out. The adherence happens on its own. And obviously, what I personally really enjoy doing and I see very good results is that involving the partner in not just the CBT and not just the pelvic floor therapy, but also in the breathing exercises, also in the dilator insertion. That is very, very helpful, and not just for the therapy itself, but also for the patient intimacy building. They is that psychology, when you've been through something difficult together, you bond better. I think it's called trauma bonding. And once they're able to overcome that together, they have a greater bonding there. So there's more satisfaction. And then they're also, you're working on the relationship indirectly, and there's a psychological element there as well. For the DHE, I'll get back to you on the brands and doses because I don't use it personally, but I can send Dr. Neeraj a message about this. Repeated posterior fourchette tears and fissures, very common, very, very common, but more often than not, this resolves with simple lubricant use. A lot of times, patients are anticipating that there will be fear, especially when they're having sex for the first time, or if their partner is girthier or has a larger penis. Something is available. I can't remember who's manufacturing it in India, but there's an American brand called O-Nut, and there's also an Indian one that I will look up and tell you, where there is essentially like a silicone ring that can go around the base of the penis that can limit the depth of penetration. So if deeper penetration or say a larger penis is repeatedly causing these fourchette tears or these repeated fissures, these can be really, really helpful. For patients who are not quite GSM yet, but perimenopausal, some local application around the posterior fourchette can also really, really help. We just want to re-establish the natural physiology of that area. And for young patients, lubricant use. If water-based lubricant alone is not helping, silicone-based lubricant can be very helpful. And in the past 2 to 3 years, you're getting so many more affordable ones. Earlier, like 5 years ago, the only silicone-based lubricant was Astroglide for 5,000 rupees a tube, and now you're getting it for 200 rupees. You're getting it on Blinkit, so it's very helpful. It's very game-changing.
And for GSM, how long you will like to continue local estrogen therapy? Till how long?
Lifelong. So we start with once daily at night, and then we move up to once or twice a week, whatever the patient is seeing better responses with and whatever they're able to comply with.
Okay, right. Because people are very much afraid to continue so long. So that's why many times.
That's true. In fact, a lot of doctors are also anxious about prescribing it for that long, but all the data that we're seeing right now is excellent data. And again, in 2026, I want to say it was in March, where the black box warning on vaginal estrogen in the US was taken off because the data doesn't support that it increases risks of any increase in cancer. And also with GSM, repeated UTIs, sepsis, so common. We can resolve that. So,
and regarding the endometriosis induced dyspareunia, so what will you prefer, medical therapy or surgical therapy? Do you see any difference between both of them?
I refer to the gynecologist. I don't deal with it.
Is there any other questions,
Yeah, that's also here.
Dr. Sharma, you can go ahead.
Yes, ma'am. Just I'll say a few situations how you handle. You may be facing many patients, like if they are postpartum and they have certain pain, how you will approach them?
If they're postpartum and they're having
postpartum pain during sexual intercourse, how you will approach in the starting phase, initial phase?
So postpartum period is usually because of lack of hormones. So we will address the hormonal issue there. A lot of times in these patients, counseling is more important than actually jumping straight into the medical therapy. These women are usually very anxious. Delivering a child is a very big experience, is a lot. And the body really goes through a lot of changes. And one of the things we speak very little about, I think we've gotten more comfortable in talking in the general culture. I'm not talking about medicine. We've gotten more comfortable in talking about sex and sexuality for young people, but we really don't talk about it in the postpartum period or the elderly patients. So geriatric and postpartum sexuality discussion doesn't really exist. So number one, reinforcing that it is okay to desire, because for a lot of them, when their hormonal shifts are happening, some people are absolutely against sex and some people really start desiring again. I personally always involve a gynecologist here, but reinforcing their belief that it's okay to desire, their body is normal, addressing their queries around the changes in their bodies, and then hormone therapy. These four things can really, really help for these patients.
So,
And the
I
situation
just
a woman with sexual trauma, means she had some abuse and now she is very much scareful to the sexual intercourse of any. So how will you approach in the initial phase to her?
This is a very important question because the vast majority of patients that come with any penetration issues have an underlying trauma history. The vast majority of patients that come to a gynecologist in India have some trauma histories actually. So including some trauma informed care, there are some courses you can do online if you want that can help you understand what are the words not to use, how not to trigger these patients, because there is already a very big vulnerability gap that is happening when a patient is coming to you. They have to be very vulnerable. There's a power hierarchy when they're speaking to a doctor, and again, with big patient loads, you cannot think about this every single day and all the time. But doing these simple things to include that in your practice, or learning these things and how to speak a little bit more gently, can be really helpful. And none of these consultations should happen without involving either a therapist or a psychologist who understands how to deal with these. And now there are a lot of trauma informed therapists. If you're not having them in your city, you can connect with them online. They are also very keen to be included in multidisciplinary teams. So having that inclusion is something that we can never provide. We will never be able to give the kind of safety and confidence that a trauma informed therapist will be able to provide, no matter how much we're coming with good intentions. So involving that can be really, really helpful. And then of course, making sure we are not going for any forceful examination, we are not going for any painful examination. And all gynecological examinations are painful, but we have to be very, very gentle, use lubricant generously. A lot of times patients really like to insert their own say speculum or even the transducer, so it can be really helpful there.
Okay.
So I just wanted to know one thing. We are dealing with a different genre of with the millennials and the Gen Z, and as far as trauma or things about sex education is concerned, do you think that at the time of adolescence, when we are really speaking about menstrual hygiene, we need to inform these youngsters about body literacy, about how to understand their own sexuality and arousals, and in case if they are really having these issues. So do you think that is also going to go a long way in trying to deal with the issues of GPPD?
100%. I've based my entire clinical practice on the basis of increasing body literacy, because what I experienced was that oftentimes when we start having these conversations at adolescence, we're already too late. These young people, the kind of access they have to information and pornography and just everything is unprecedented, and we are not prepared to deal with that. They come in with so much. A lot of times the things I learn from my patients, because I had no idea. Now there's some new trend that's happening where they already know about this. And when I say my patients, I mean as young as 14 and 15, they already know so much more than we could ever learn in medical school. So if other doctors have the time, I really encourage more and more doctors to either create content or get involved with local bodies and start talking about sex ed. I don't think there's a right age for sex education. I think it has to be a graduating conversation that happens at every age. At a young age, they should be told about their body. At a slightly older age, they should be told about sex and sexuality. At a slightly older age, they should be told about contraception. Because, young people are having sex left, right, and center. And they are landing up with issues with it. And then they are landing up with lifetime issues with it, like GPPD. So it's a difficult time. I'll just say that.
Do you face patients who are approaching you premarital counseling or after marriage couple counseling with this complaint of vaginismus, and they want to improve their sexual life? you encounter such patients?
Vast majority of my patients are unmarried.
Okay.
Because it's happening rampantly, and unfortunately, because of the way we are taught medicine and because of the kind of socio-cultural context of our country, these people want to go to a doctor, but more often than not, they're yelled at and sent home. So this is, I mean, keeping our personal biases aside, I think this is a place to offer care. And when we don't do that, there are longer term consequences that we only deal with at the end. So might as well step in early.
Yes, ma'am. Neeraj sir, any questions?
Is there any role of anti-anxiolytic tablet or treatment in such group of patient?
So if there is an anti-anxiolytic treatment involved, I usually refer to the neurologist or to the therapist.
Okay.
I personally don't prescribe them, but yes, there is data to suggest that. But it all should happen on the foundation of CBT plus pelvic floor therapy, because even if the patient is performing very well in their pelvic floor therapy, they can still be very anxious in the moment itself. So having an anxiolytic can help here.
Right.
Okay, sir.
Purva, are you there?
Yes, sir, I am there, sir.
Is
Hi,
there
ma'am.
any question?
Yeah, actually, yes. Ma'am, I just want to ask you one thing. Some people are saying there is a secondary vaginismus. Okay, so is really relevant that can vaginas be secondary? Or can vaginas be partner specific?
Absolutely. So we can have generalized, we can have lifelong. It can be partner specific, especially if there's an unsafe relationship, number one. Number two, the partner's penis size and penis girth really matter for some people if they've been hurt physically, not emotionally, by their partner's penis, then there can be a fear avoidance cycle that can set up. And secondary vaginismus, yes, absolutely exists. Hormonal issues can change things, body image issues can change things. So very, very much it exists. It doesn't have to be a primary thing. It doesn't have to be something that sets in from the very first experience of intercourse. And there documenting that is very important in how we set the treatment protocol for this patient.
Regarding the Indian context, we have a lack of privacy in a majority of Indian homes, and there is a lack of foreplay also in most of the cases. So, is it a considering factor in such patient, or it's?
Absolutely. So the patient that I was mentioning about, who was very active with her boyfriend of 10 years and then had secondary vaginismus after she had some mental trauma seeing her father-in-law peeping into her room. So that kind of experience can strongly impact how patients experience this. And then lack of foreplay is a very common thing. The kind of ideas we have around virginity and sexuality, young people are not counseled about how to involve foreplay, and how a lot of them don't even know that the vagina is supposed to dilate, and it's supposed to, the tenting is supposed to happen for making space for the penis. So when the first intercourse happens, there's already anxiety, plus tenting hasn't happened, so now there's more pain, and it becomes a self-perpetuating cycle. So very, very common. And I think you've hit the nail on the head, because that is usually the primary reason why these things develop for most of these patients who are even having sex, after marriage or however they're choosing to do it. And this is probably the most common presentation, most common history we see.
Okay.
So,
Neeraj sir,
no
any
more
other
question? Yeah.
So thank you so much, ma'am.
So I think, vote of thanks.
Yes, I'm honored to give vote of thanks, and on behalf of SexMed Connect team, I extend my heartfelt vote of thanks for today's enlightening session of Sexual Health Ki Pathshala episode 7 on GPPPD. Sincere thank you to our esteemed faculty, Dr. Tanaya Narendra, for sharing valuable insights with clarity, compassion, and scientific depth. Your session has truly helped us understand an important yet often under-discussed aspect of sexual health. We express our gratitude to our wonderful co-moderator, Dr. Rinku Lodha Negi ma'am, for gracefully conducting the webinar and keeping the session engaging throughout. And a special appreciation to our Neeraj Yadav sir, Dr. Apurva Datta sir, and Naisargi, and for the support and constant support and vision in making such academic initiatives. Our sincere thanks to Medisage and Sage AI for co-powering this educational platform and helping doctors connect, learn, and grow together. Finally, a big thanks to all the participants for your active presence, interaction, and enthusiasm. Your involvement makes these sessions meaningful and impactful. We hope to see you again in the upcoming episodes of Sexual Health Ki Pathshala. Thank you. Thank you
Thank you
so
so
much.
much.
Thank you, Dr.
Thank you.
Tanaya. This was really wonderful. So really nice to connect with you.
Thank you so much, sir. Thanks for this opportunity.
Thank you, Rinku and Sama.
Thank you, sir.
Thank you, sir, for this opportunity.
Okay. Good night, everyone.
Good night.